Welcome everybody. Thank you so much for being here. My name is Tony Marchant from the March Centre. It gives me huge pleasure to introduce Dr. Katherine Semrau from Brigham and Women's Hospital and Harvard Medical School. And Katherine is leading the BetterBirth trial in Uttar Pradesh to learn how to implement and test for morbidity and mortality impact the WHO Safe Childbirth Checklist. And she's going to talk to us today not about the final results, which is infuriating, but about emerging evidence. So Katherine, and I think Katherine will speak for about 30-35 minutes, and then we'll have time for questions at the end.
Great.
Thank you.
Thank you. Hi everybody, how are you? Good. My first question is, has anybody actually heard of the Safe Childbirth Checklist before tonight? A few people. Okay, great. That gives me a sense of people's backgrounds. So first of all, I want to say thank you so much to the Ideas team and to the March Centre and the London School for hosting me today. It's been a great day of meeting many of your professors and faculty and the work that you all are doing. So the way to start is, I think we all know that globally there's about 300,000 women who die during pregnancy and childbirth, about 1.3 million interpartum-related stillbirths, and about 2.8 million neonatal deaths around the world. But those global numbers hide a lot of diversity and differences in mortality rates across different geographies and even within the geographies. I'd like to highlight here that neonatal mortality in India is just below 30 deaths per 1,000 live births in 2013, but in the state of Uttar Pradesh, where we are working, it's actually closer to 50 deaths per 1,000 live births in 2013. And those mortality rates have persisted to be very high, even though we have really focused on getting women to deliver in a facility. So with skilled birth attendants, with facility-based delivery, at 70% in Uttar Pradesh, you see this blue dot here, we're still seeing very high neonatal mortality rates and still persistently high rates of maternal mortality and stillbirth. Now, during a woman's pregnancy, the highest risk of mortality is right around the time of childbirth. So when she comes into the facility or when she actually goes into labor, through the delivery process, and then in the first 24 hours postpartum. That's also the highest risk for the neonate, is right at the time of birth and within the first 24 hours postpartum. And it's not that we don't know what to do. We actually have known for about a century what are the basic evidence-based practices that prevent mortality for the mom and for the baby. You can see here a basic list of early referral, so making sure women, if they're having a complication, are getting to a facility that can actually manage the complication. We are seeing that magnesium sulfate to help treat eclampsia and preeclampsia needs to be available in the facility to provide care. The basics of hand washing and sterile fields or proper hygiene around the time of vaginal exam, around the time of labor and delivery is also very important, but often unpracticed. In our facilities in Uttar Pradesh, we had independent data collectors go in and just watch some deliveries and see what's happening. So in 10 different facilities, these are frontline facilities, primary health centers, community health centers, where the majority of women deliver. The independent observers watched about 603 deliveries, and this is the uptake of some basic practices. So you can see at admission, before a vaginal exam, hand washing with water, just water, was less than 10%. The use of soap was less than 5% of the deliveries. And alcohol rub, which has been touted as a nice, simple way to promote hand washing and hand hygiene, has not been used at all in these facilities. We're also not seeing basic vital assessment happening. So blood pressure taking and temperature taking at admission happen less than 5% of the time for women who are coming to a facility to deliver. On the positive side, we're seeing that supplies are available for the most part. It's not perfect, but we do see that pad availability, the neonatal bag and mask are ready at the bedside of the labor and delivery room. The cord tie, so you can actually, and cord blade to cut the cord are available. So supplies are there, but the practices aren't. When we look at, postpartum, in the first minute postpartum, you need to administer oxytocin to prevent postpartum hemorrhage. Now in India, in this context, oxytocin is being used to augment labor a lot in about 80% of women while they're still in labor to try and speed up labor and delivery. But the practice, the evidence-based practice, is actually delivering oxytocin within 1 minute postpartum to stop hemorrhage. And again, that's only happening in about 20% of the cases. So the basics are not being done, and that's often been described as the no-do gap. The skilled birth attendants have the knowledge, but they're just not practicing it. And there's a lot of reasons why. It's not just motivation or opportunity. Sometimes it's a supply issue, and sometimes it is an ability issue. To address this no-do gap, the WHO's Safe Childbirth Checklist was developed in about 2008 and 2009 with a community of experts who came together and started to list out all the different behaviors that should be done, and through an iterative process, whittled that down to about 28 items on the checklist. Now, checklists have been used in other areas of industry and in health. So on all the airplanes that you fly, a checklist is used by the pilot before takeoff, during flying, before landing, and are highly effective at preventing accidents and errors while flying. We've also seen that checklists have been used in surgical field. So a safe surgery checklist is 18 items and has been shown to be effective in reducing morbidity and mortality related to surgery. So this same strategy has been applied to childbirth. And it has 4 pause points, so at admission, just before pushing, within the first hour postpartum, and at the time of facility discharge. And just so you have a little bit of a closer look, I hope you can read it from the back. This is pause point 2, which is just before delivery, just before pushing. And you can see that the way the checklist is designed is on the left-hand side is the prompt, the question, does the mother need antibiotics? And on the right-hand side are a few more details about what are the things you need to know to determine if the mother needs antibiotics. For example, you should know her temperature. You should know if she's having other danger signs of infection or risk of infection. Now, the checklist has been taken up in about 34 groups across 29 countries as part of the WHO Safe Childbirth Checklist Collaborative. And that collaborative completed its work in about mid-March 2015. As the checklist was being designed and iterated on, it got more narrow, tighter in terms of the number of practices that are on the checklist. And that collaborative worked together to understand how people were implementing the checklist. And there was a successful pilot in Karnataka study that our team did previously in about 2010 that looked at what is the impact on birth practices, so birth attendant practices, with them using the checklist. And they saw a successful uptake of behaviors with the checklist being adopted. And now we're running this enormous trial in Uttar Pradesh of 172,000 mother-infant pairs. Now, the checklist has been taken up in many settings already, even without having mortality impact data, because it is a tool to try and improve the quality of care for women and children. So the countries that are highlighted in yellow are about the 23 countries that we at Ariadne Labs have been supporting to take up the checklist, and people have been using different implementation strategies. Now, the implementation strategy is a really key point and component of what we do at Ariadne Labs. Just the checklist alone, we know is not going to implement itself. Checklists in safe surgery were mandated to be used in Canada and had 0 impact on mortality. So it's not just about mandating the use of the checklist. It has to come along with a strategy to implement. So we use a strategy called Engage, Launch, Support, and I'll go through what those different components are. So in the engagement process, we're really focused on communicating with facility leaders, people who are empowered to make decisions, policymakers who will agree to take up the checklist. We have a launch, which gets the frontline workers excited about the checklist. Let them understand what's on the checklist, what is it all about, how is it not a new piece of work, an additional component to their day, but how it streamlines into the process of labor and delivery. And we focus on the support process. So it's not just introducing it and say, you should use this. It's talking about a coaching process to encourage the frontline workers to use the checklist, give them feedback about what they're doing, and how the uptake of the checklist and adherence to the behaviors is improved. And the idea is that we believe this strategy may strengthen the individual and systematic approaches and behavior change, as well as improve maternal and newborn health outcomes. And like Tanya referred to, we will have outcome data in early 2017 that I'll be happy to come back and share, but we don't have that information just yet. So that strategy is being tried on in several settings, those countries that I highlighted previously, but everybody has a slightly different strategy of implementation. We're actually testing this implementation strategy through this very large trial in Uttar Pradesh. So the idea is, does this implementation package, with focus around the WHO Safe Childbirth Checklist, first of all, improve the birth attendant behaviors so that the care that women are receiving is better care at the facility? And second of all, do we see an impact on early, so before 7 days postpartum, mortality and morbidity, as well as perinatal mortality? And we have a lot of partners who are involved in this trial. As you might imagine, it takes a lot of team members to pull off a trial of 172,000 women for follow-up. So the trial itself, this is a map of the state of Uttar Pradesh. UP, like all things in India, the population size is very large. So 203 million people live in Uttar Pradesh, which is 2/3 of the population of the United States. We are only working in 120 facilities, which is large for a randomized control trial, but relative to the total number of facilities in the state, not that big. We have 60 intervention sites and 60 control sites, and we are working on that coaching plus checklist strategy in the 60 intervention sites. In both intervention and control sites, we are observing birth attendants and watching their behaviors to see what practices are being adhered to and what are not, as well as following those 172,000 women who come to the facility for delivery, following them up using a call center to find out what their outcomes are. So the implementation strategy, as it is in the BetterBirth trial, first of all, we were very fortunate that the checklist is actually already incorporated into the maternal and newborn health toolkit in India. It's already government sanctioned, approved, so it wasn't like introducing something new in terms of policy into the government of India. So having that helped us be able to introduce the checklist into these facilities. Like I said before, that engagement process is critical at both the district level as well as the facility level to make sure that leaders are comfortable with the checklist being adopted and the trial coming into the facilities. Second, we use that launch with motivational videos, which are available on YouTube, and one is in a Bollywood-style dance video to encourage the uptake of the checklist, as well as perform a gap analysis with the facility workers to understand what are their concerns about the facility's ability to provide high-quality care and their individual concerns. Third, we focus on coaching with a peer-to-peer coaching model that's influencing the adoption of these checklists, as well as giving data feedback for change. So empowering the coach who is providing this mentorship to the frontline worker with information about how that birth attendant is doing, how the facility is doing in terms of behavior change, and giving feedback to that frontline worker on a consistent basis. And for sustainability approaches, the idea is to focus on empowering someone at the facility level as well as at the district level to become a childbirth quality champion or coordinator. And the idea is that they gain the skills of a coach. They are able to continue the work after the trial itself is finished. Now, what does coaching mean? You may hear in the literature right now, there's a lot of focus on nurse mentoring, coaching, hand-holding, supportive supervision, all different nouns for similarly the same thing. And the idea here is that the coaches work hand in hand with frontline birth attendants and with the management at the facility to focus on adherence to the checklist, ensuring that care is properly provided. But you should know in the trial we are not changing the supplies and we are not providing skills training directly. The nurses have already received their skilled birth training, and supplies are managed through the government systems, but we do help support the government systems in terms of giving feedback to the facility in charge about what supplies are available and what are not. The coaches, while observing and coaching the frontline birth attendant, are also gathering information and recording down what behaviors are done and what behaviors are not done. And that is fed into an app and generates that heat map that you can see there on the left-hand side. It uses the basic stoplight colors, red, yellow, green. Red means a behavior wasn't done. Yellow means that the coach prompted the birth attendant to do the practice. And green means that the behavior was done by the nurse themselves. And so those heat maps are used for by the coach to help generate what should they focus on. What is the birth attendant doing well? What are they not doing well? And that feeds up to a facility level feedback. So the approaches that we've been using are really focused on this peer-to-peer coaching with a focus on barrier identification, which I'll show in a second, as well as problem solving for behavior change. Giving real-time data feedback has been a critical component as well to this implementation strategy, and of course focusing on sustainability. One of the things I wanted to highlight that we learned through our pilot studies is that peer coaching was the model that worked best in Uttar Pradesh, but in other contexts we have found that physician-to-nurse coaching has been effective. That was actually the strategy that was used in the pilot study in Karnataka, was a physician coaching nurses, and that worked very well. When we tried that in Uttar Pradesh, that failed miserably. And it needed to be a nurse-to-nurse coaching and a physician-to-physician coaching to improve behavior change. Second, we want to focus on barrier identification. So if a practice is not done, why is it not done? You can't just say, you should go do this to the nurse. You have to talk about why a behavior wasn't practiced and what is needed to facilitate that behavior change. So up at the top here, I'm showing you the observation tool that the coaches use to identify why a behavior wasn't done, and we categorize them into this OAMS framework that we've been using, which is about opportunity, ability, motivation, and a supplies issue. Now, it's possible that it's more than one barrier for each different behavior, why something wasn't done. But the coach works with the birth attendant to understand what is the barrier and then how can you resolve that problem. And the idea is to facilitate the birth attendant to be able to start identifying what are their own barriers and then start problem solving for themselves. Now those heat maps end up generating at the individual level and come to the facility level. And I know this is a very busy slide, but the idea is just to show you the color trend over time that we start to see we're moving from red to yellow to green. But we do have areas that pop up that are still problematic, and that behaviors don't consistently stay green or get done all the time.
Are the columns providers?
The columns are observations. That's a good question. So this is across a facility. You can look at the behavior report by individual birth attendant, but when you aggregate it across a facility, it's just over time. Now, feedback is not only provided at that front level worker, but also to up the hierarchical chain. So focusing on, yes, giving feedback to the birth attendant themselves, then giving feedback to the officer in charge, the medical officer in charge, that head of the facility, and then to the district level, and then to the state level. And that's been an important component of making sure the supply availability improves, because oftentimes the district level staff don't always know what supplies are available and what are not through the normal reporting systems. And finally, empowering the district and the facility level coordinator to focus on becoming champions themselves to work in the facility going forward. So the BetterBirth coaches work to identify a facility staff member who has social gravitas, who is acceptable to the other birth attendants, to help provide support going forward. Sometimes that is another birth attendant in the labor and delivery room. Sometimes it's a pharmacist or a lab tech, but it's someone who has the ability to gather people together, identify where the barriers are going forward, ensure that checklists are available, and continue to champion quality of care work after the trial is finished. So this is one of the report back systems through the district progress meetings where information is given to the chief medical officer as well as the medical officers in charge at the facility level. So all is well and good, and we're focused on implementing the checklist and getting buy-in from the birth attendants. This is a picture of the oath that is taken as part of the launch, where people say that they are committed to working on this and want to be working on providing better care. But the question is it having an impact? And so now I'd like to walk through some of our initial results that we're seeing in the trial, and then talk to you a little bit about where we're going next with this work. So for the analyses that I'm about to present to you, there's the coach data, which I just showed you in that heat map. From the research side, there is a separate cadre of workers who come into the facility and observe labor and delivery. They do not interact with the nurses. They don't provide any guidance about what practices are done or not. They are completely separate from the coaches themselves. They go into the facilities and document what's happening at the first three pause points. So at admission, just before pushing, and within 1 hour of delivery. We haven't been able to have researchers observe discharge because it happens at such varied times across the facility. So these are behaviors that are only happening in those first three pause points. We are also calculating a composite score. So out of 18 basic behaviors, which are listed here on the right, these are basic practices that every woman and child should receive. So for example, is a birth companion available with the woman when she's admitted to the facility? Did the partograph get started? And that has been a challenging behavior to change. I'll show you shortly. Just before pushing, are all these supplies available at the bedside for the woman to be able to deliver safely? And then within a minute, is she receiving oxytocin to prevent postpartum hemorrhage? And then again, within an hour, was the baby's weight taken? Was the temperature taken? And was skin-to-skin initiated and maintained for the first hour postpartum, as well as breastfeeding initiation. So we see at baseline, like that's going back to that slide I showed you at the very beginning, out of those 18 behaviors, on average, only 6.5 are provided to any given woman at her labor and delivery process. You can see that it's equal between the intervention and the control sites. That shows us that randomization worked, but it also tells me that quality of care is universally not very good at these facilities. But after an intervention, after 2 months, so 8 weeks of coaching, at the same point in time we're measuring in the control sites as well and the intervention sites, we see that we've almost doubled the number of practices that are provided to a woman on average in the facility care. So 13 out of the 18 practices are provided for intervention sites, and still 7.5 out of the 18 in the control sites. Now, this tells you a couple things. First of all, we're seeing improvement, but it's definitely not perfect. We haven't gotten to 100% in terms of the care that's being provided. And the question is, what's changing and what's not? So if we look at what are the behaviors with the smallest and the greatest improvements, I can show you here on the left-hand side. So on the gray bar is the control sites, in the blue bar is the intervention sites. And you can see that for partograph, nobody is starting partograph. It is extremely rarely practiced, and we have found this consistently across all of our sites. We think it has to do with a couple of things. First of all, the training that the birth attendants received may have been quite some time ago, and they didn't use partograph consistently, haven't started it. Second, the physical piece of paper on which the partograph is charting is not present in the facilities oftentimes. And third, if you speak to the nurses, they will tell you often that the women are coming in so late that they're already very advanced in their labor and delivery and just deliver very quickly, and there's no time to start the partograph. So we didn't see any improvement there, intervention site or control site. When it comes to hand washing, which is this middle bar here, we're seeing that, like I showed you at baseline, hand washing behaviors are very, very poor. Less than 5%. In the intervention sites, we were able to get that up to about 36% of the cases had proper hand washing plus gloving before a vaginal exam, which is dramatic improvement overall, but it's not enough. Clinically, I wonder how significant it is to have just a 36% increase in hand washing. Then there are other behaviors that we're really seeing great uptake up to the level of 80 and 90%. So provision of oxytocin within 1 minute postpartum has gone up to 80% in the intervention sites and still remains at 20% in the control sites. Breastfeeding initiation, which goes right along with skin-to-skin initiation, has also dramatically increased in the intervention sites compared to the control sites. And finally, a supply that's quite different in the intervention sites is this clean towel availability to dry off the baby. And when we say clean towel, it means actually like sometimes it's a sterilized towel or dry towel, as opposed to using the same towel that was originally used to catch the baby and then wrap the baby in that. So the babies ended up staying quite wet, which is dangerous for hypothermia. The question is, why are some of these behaviors changing so rapidly and other ones are not at all? We think it has a little bit to do with what is the visual outcome that you see when it comes to oxytocin. Within 1 minute, you actually see less blood and less bleeding, so there's a visual impact. And nurses have reported to me that the skin-to-skin initiation has also changed their perceptions because their perception of the health of the baby, because the baby's color pinks up. They look warmer as they're doing skin-to-skin as opposed to being kept separate from the mom. Yes? Oh, thank you for that catch. So I should highlight that's actually two different things. So the first is skin-to-skin initiation. So was the baby put skin-to-skin immediately after birth? The second one is skin-to-skin within 1 hour. So maintaining the skin-to-skin action for an hour. That only increased to 20% in this setting. So that's another behavior that needs to be worked on in the intervention sites. And the question is, why is that? Well, in Uttar Pradesh, part of the cultural norm is that once the baby is born, the baby is dried off, baby weighed, and then handed to the family, because the family then takes the baby out and shows the baby to the rest of the family outside of the labor and delivery room. And that happens very quickly after birth. And so that maintenance of skin-to-skin within an hour has taken a lot of work. Birth attendants have had to explain to families why they think skin-to-skin maintenance is so important. And again, it's going against a cultural norm in this setting. So if you look at what's adhered to at least 50% of the time in the control sites on average, you're seeing that a lot of it is supply related in both intervention and control sites, where you're seeing cord tie availability and neonatal bag and mask availability, as well as some presence of birth companions, and the baby weights being taken and clean gloves are being used in both intervention and control facilities. But in the intervention arm, you're seeing other behaviors that are also taken up more regularly, with some of them are supply related, but also you're seeing more behaviors. So vital sign assessment, focusing on oxytocin administration within the first minute, and finally skin-to-skin and breastfeeding initiation also improving in those sites. Now, one of the questions is it the coaching or is it the checklist? And it's very hard to separate those two in this trial. The one analysis that we can do is look at what is the relationship between checklist use and these different behaviors that we're seeing at the facility. So overall, in the intervention site, at 2 months after the intervention started, checklist use measured by the independent observers was about 75% of the deliveries had a checklist used during that labor and delivery process. So we took in the intervention sites, and I know this is tight to read, but I think it's important to show the variation. We showed in the gray bar is the behavior uptake with the checklist not being used. And then the blue bar is the checklist is being used and what's the behavior uptake or adherence there. So to highlight, so birth companionship in pause point 1 in admission doesn't change whether you use a checklist or don't use a checklist. It's a cultural norm that an ASHA or a family member accompanies a lady to deliver at the facility. So that's standard. So not shocking that the checklist had nothing to do with that behavior. But what you do see is, like, for proper hand hygiene, so before a vaginal exam, are hands being washed and gloving being done. When a checklist is used, you're seeing higher uptake of that proper hand hygiene, closer to 50%, whereas if you're not using a checklist, the birth attendant's not using a checklist, it's closer to 20% uptake of that behavior. So you can see that it's not just the checklist alone. There are some behaviors that are sticking whether they're using the checklist or not. But I would argue that some of the behaviors like vital sign assessment, so temperature taking, blood pressure taking in particular, are much more likely to be done when the checklist is picked up and used as compared to not. Even though this is in the intervention sites only, and everybody has received the coaching and knows about the checklist, has it available to them. I think some of that has to do with, on the checklist, there are boxes to write down what is the temperature, what is the blood pressure. So it's a prompt to remember those kinds of things, as well as provide feedback to the nurse to make them sure they check and know what they've done.
And Katherine, the ones where, I mean, is there any difference among the ones where the checklist's not used has got a higher?
Yeah, so it's not statistically significant, but the mucus extractor availability for some reason was a little bit higher without the checklist use. Not really sure. I haven't figured out how to explain that one yet, but I will work on that.
So, do you know things like, is it that they're, say for example, if it's like a terrible emergency, so it's like, I would imagine that's the case where both you don't use the checklist and you don't
Right.
handle it. Do you have any way of looking at the type of delivery?
We will after the fact. So at this stage, I don't have that information in this data set. What we do have being collected right now is every woman who's observed, we will have their outcome data, and we will also have their facility register data, which lets us know, is she referred, was there a complication, what's the outcome of the mom and the baby at the facility, as well as at 7 days postpartum. So that connection, I think, is a really great analysis to do. All of this to say is we are now at the phase where we hope, go ahead.
Sorry, I just wanted to ask something to clarify.
Sure.
Was the checklist used also when there was not a coach present? Because I can imagine that there wasn't a coach at every delivery.
So I should advise, this is all, coaches are not present at this, when this data is being collected. So any independent, all the slides I just showed you, I'm sorry I didn't clarify that previously. All the data that I showed you before is independent research data staff who are standing back and watching, but they are not interfering and they are not prompting to use the checklist. So no coaches available.
But are the attendants aware that the people, the independent data collectors are there, or they actually don't?
They know that they're there, but they are there over quite a long period of time, for about 6 to 8 weeks, in order to collect the number of observations needed. And you know what you're concerned about is the Hawthorne effect, right? Like somebody.
I'm concerned about the fact that they'll only take temperature or do the BP reading because it's someone observing.
It is a concern, but what we've seen in some other research is after observing people for a couple of times, 2 to 3 days consistently, they revert back to whatever their standard behavior is, and this is over that period of time. So one of the sub-analyses to do is like drop out the first 3 to 4 days of observation and see if you're still having this kind of difference. Yes, ma'am.
In terms of perinatal data, what sort of data are you looking at? So is it just an outcome of a live death, or are you looking at infection, non-infection? Because prenatal antibiotics obviously won't be a checklist as a mother had antibiotics, and that's very much related to early onset and later sepsis.
It's a great question. So we will have extensive data on maternal morbidity and maternal mortality. We will have perinatal outcomes. We do not have perinatal infection information. The status that we'll have on the neonate is a facility, so stillbirth, live birth. Then we will also have outcome at 7-day discharge. We are taking the information out of the facility registers to understand what the staff recorded as complications or problems with the neonate, but understanding the limitations of register data, which is complicated, but it is the best that we can do.
You're recording outcome at 7 days, and then you're recording whether the baby's alive or dead.
Yes, yes.
So we should probably let Katherine, because I think that's exactly what she's going to move on to right now.
Oh yeah, no, so just quickly, so the idea is like where are we going, right? So this looks really exciting and promising after 2 months of coaching, but is that sustainable? Is that what we're going to see consistently after 6 months of coaching or 8 months of coaching? So those are the first sets of questions. Second sets of questions is this having an impact? And what level of impact is it having, and is that impact sustained? So as this woman is leaving the facility with her healthy baby, that's what we're all aiming for, right? And improving the quality of care that women and children receive at a facility-based delivery. But we are now at the stage, we've enrolled 146,000 women. We have followed up, we have amazing follow-up rates at 98%, and the way we've been able to do that is with a call center that's based out of Lucknow in Uttar Pradesh. That call center, you know, one of the great things in India is that cell phone coverage rates are extremely high. It's not been my experience in other parts of the world that I've worked. So it's been a real advantage of being able to follow up women through a phone call. If we can't reach them through a phone call, then we do a home visit where the questions are asked about mortality and morbidity and other follow-up questions. So I think that's our goal right now, is to have that data available in early 2017, and we'll see if it's had the impact that we hope that it does. We do have a set of implementation resources that, Nabiha is actually here, my colleague from Ariadne, who helps focus on supporting communities to implement the checklist, and they've been implementing it in a variety of ways. So our colleague in Namibia is using physician-nurse coaching at one district hospital in the eastern part of the country. Other people have used midwife-to-midwife coaching around the checklist. It's been a real variety of strategies. We're trying to capture those strategies to understand what's effective in different settings, in different contexts. So I'll give this resource as available as you all see fit and need to use it. And of course, to acknowledge all the partners that make this work possible, and especially the women and children who have signed up for the study. And I'm happy to take any questions that you may have.
Thank you. Sure. Thank you. And you've already had some questions, to be fair.
Sure.
That's only because we're all so interested. So, yes, please, go ahead.
Thank you, that was really interesting. I'm wondering about trained health workers or like formally trained health workers and informally trained health workers.
Yeah.
Because we know that there's so many in these facilities that don't have formal education. I'm wondering if you're looking at any results, any effect that could have on them, or if you're seeing a different response, also in response to coaching, or different types of reactions there.
That's a great question.
And also how you find, like how you negotiate working in that environment, because that's probably a bit political.
Right. So one of the reasons we can't do skills training is because we are not officially part of the government, and therefore no skills are allowed to be passed from us to the frontline worker. However, we work with that community to figure out how do you get the skills training to come into the facility. So working with the head of facility, the lady medical officer, if a birth attendant doesn't know how to properly take temperature, finding out someone who can properly train her how to do that. With respect to who's the birth attendant and what's their cadre or training, and then what are their outcomes. So the answer is yes, we'll be able to assess that on the 7,500 deliveries that we're observing. And there's a real combination of who's helping out in the labor and delivery room. There's an auxiliary nurse midwife, which has less training than a staff nurse, which has less training than a lady medical officer, and then a physician at the top. Most of all, it's been an auxiliary nurse midwife or a staff nurse that have been providing it. However, what's happening at night is different. We know that DIs, who are the cleaners of the labor and delivery room, are often actually providing a lot of the labor and delivery care. We've actually observed it, so we have it documented about who's providing the labor and delivery care during the daytime. So that at least is one analysis that we can do. The other analysis we will do is based on time of delivery, so looking at children who are born at night, like is the checklist program having a difference in those kids as well as the kids that are being delivered during the day? Because we know that staffing dramatically changes during the night, especially. So we will be able to measure it, we just haven't looked at it yet.
Sorry, I just had one more question, but maybe I didn't hear when you said it, like how the coaches are recruited. Are they from the same hospital?
Excellent question. So right now the coaches are external they are hired by Population Services International, which is our implementing partner in UP. They have at least 2 years experience as a nurse or more. We have some of the nurses who have, like Parvati has 30 years experience or something as a labor and delivery nurse. So they are typically younger than most of the staff nurses that are at the facility, which has been a really interesting relationship dynamic to navigate of how do you build rapport. So part of the coach training is focused on relationship development, rapport building, and not just like you should do this on the checklist, but focusing on why behaviors aren't done and how to encourage people at the front line. So the coaches are nurses by training, have experience, and there are also the coach team leader, who is someone who supervises the coaches, provides physician to physician or public health specialist to physician coaching for that leadership level. Yes, ma'am.
I actually have two questions. One is on I'm not very clear how the tool itself, the checklist, is used for like complicated deliveries or referrals or even identifying the high-risk pregnancy or labors that need referral. And the second one is presumably over time, because of the caution and the heat maps, there would be additional interventions within the facility, say additional training or changing how supplies are provided. Over the course of the study, how will you then control for the effects of this additional?
That's a great question. So we're gathering through quarterly surveys. We're gathering supply information to understand what's actually available at the facility to try and control for that. Because we do think that the intervention itself is impacting supply availability itself. Because there's just more communication between the frontline workers and the head of facility, as well as the head of facility to the district level teams. We also have quarterly surveys on checklist utilization. So in the intervention staff, how are they feeling about the checklist? Is it too much work? Do they use it? Do they not use it? That are anonymous surveys that are done by the intervention sites, as well as what we call a safety attitudes survey. So as a clinician providing care during labor and delivery, how do you feel about being able to give quality care? So it's a Likert scale survey that's done that's also anonymous for that. With respect to how does the checklist work? So part of the checklist, and I don't have a graphic of it, I'm sorry, but is POS point 1 is all about, does this woman need to be referred? Like, of these danger signs, are these popping up? Is referral appropriate? And what's the referral strategy that you're going to take? It is not designed to manage hemorrhage. Like, for example, the checklist right now doesn't tell you what to do in case of hemorrhage. There are, and it's been an interesting debate, because in Uttar Pradesh there's another project that's using something called a case sheet, which is a much longer document. It's more like a medical record, to try and prompt nurses to remember that, and it includes the complications cascade. So if this complication is coming up, here's what you do. So I think that's an area that is for a lot of exploration and growth, is understanding how to manage complications better, and how the checklist can either be extended to do something like that, or refer to another tool that can help manage complications better.
Can I ask another question? Is there any observation related to the timing of the care provided? Basically, I've had workers spending too much time filling out the checklist, actually attending to the visit.
Yeah, so there's a couple different ways that the checklist can be used. It can be used as called a read-do, so you go through it and you do the action as you read through. Or at the end of care, you go through and make sure that you have provided all of these things. That's called a read, do, and then do, confirm. So you do the actions and you go back and check on the checklist, like, did I do this, and this? So the idea is that it's being streamlined into the standard work, but it is creating a pause point, like a true stop, like make sure everything is being done properly.
I want to jump in with a question.
Yes.
Because I know that Ariadne Labs have been really engaged in the scale-up, and scale-ups happened rapidly and in many different settings. If there is the eventuality that you get mixed results from your trial, are you aware of any other implementers, any other scale-up efforts that are generating similar sorts of evidence? Or how will Ariadne Labs deal with an outcome
It's mixed.
that's mixed?
It's a great question. I think a couple things. First of all, I think if we have mixed impact on mortality and morbidity, but we're improving the behaviors that are being done at the time of labor and delivery, it seems to me that the improving behaviors in and of itself is a good thing. Like streamlining the work, getting people to just make sure that it's being systematic in terms of care is a good thing. Japaigo has a very large program in India called Dakshata that is using the checklist as part of their implementation strategy. They are gathering some evidence on outcome information, but a lot of it's based on facility register data. There is part of the country teams that are implementing the checklist or thinking about implementing the checklist that are in touch with us are also trying to figure out their monitoring and evaluation plans around whether it's having an impact or not. And I think those are other areas to gather evidence about what's working and what's not. Do you want to add?
Yeah, if I could just add
really important in this process of scale up across different countries is understanding what is their implementation model, and similar to our UP experience is understanding what are some contextual factors that may or may not contribute to the result that we might see. So a lot of the countries we've supported are looking at behavior uptake, and that's an important lesson to capture. None of the projects that we've supported, at least that we know of, are testing morbidity and mortality to the same extent that we are in India. But I think it's an important learning that we'll come out with in terms of how implementation varies and what factors might contribute to different types of outcomes.
Thank you.
Thanks, Navia. Yes?
The investigation into sort of the contextual factors across different settings consistent, or are you, I mean, is there some collaboration and conversation going on about what kinds of contextual factors
You want to, you can talk about.
Yeah, so we have a formal partnership with WHO, of which many of the countries that we've helped supported in testing the relative impact of the checklist are part of. And as part of that collaboration, we've been doing a webinar series, and we've also been trying to systematically collect information and then share across the collaboration. So we recently completed an evaluation report looking at implementation strategies and found a lot of consistency in terms of the approach. A lot of the approaches we've seen follow a similar model of engagement across the system, some sort of formal training or launch event, and then some sort of ongoing support. It's certainly varied across contexts, but we are trying to, institute a more systematic process of that learning and of that collaborative approach to understand what are the similar or different contextual factors.
It's okay. Hi, Peanut. Hi, Anna. Yeah.
I also just really enjoyed that, and I think you're doing so many innovative and
Oh,
nice
thank you.
things. I don't know if this is an appropriate question.
Sure.
Don't answer it, or if you don't know. But how much does a trial like this cost? 'Cause
Oh.
I think it's useful to know.
Yeah.
If you're talking about 170 million.
Yeah.
170,000 women and a huge number of facilities.
Yeah.
Ballpark is fine.
Yeah. It's several $1 million right now to do the trial. I mean, it's upwards of 15 million, a little bit past that. So I think the thing is we are doing a cost effectiveness analysis because we as Harvard, we as researchers are not, part of the program itself. So we actually are doing a cost effectiveness study within the trial to look at, what did it actually cost to implement the program? What would it cost to implement this across UP? And what's the effectiveness? We're also doing and I'm not an economist by any stretch of the imagination, so I've learned a lot about cost effectiveness analyses in the past couple months. But Dr. Stephen Resch, who's from the Harvard Decision Sciences Center, we've also been collecting this data on what's called work sampling and time motion studies. So I always confuse the two, but I'll try to get them right. So work sampling is like looking at what is the nurse doing every 2 minutes and recording what's happening every 2 minutes, so you have some sense of what is their workflow in the day. And we're doing that in both control and intervention sites to understand, is the checklist adding to people's work time and what they're doing? The second is, how long does it take to do the things that are on the checklist? So how long does it take to take a blood pressure, to take the temperature properly, to give oxytocin, all of these things? And that will give us some sense of if you're adding more to people's work because they're doing the things that are on the checklist, where are you moving their time from? So are you removing time from their downtime, or are you removing time from their other work activities, which would be a problem? And then the time motion study gives us an idea of how long does it take to do the things that are on the checklist. So that idea is to get to a cost-effective program as opposed to a very large randomized controlled trial going forward. You want to add?
Oh, yeah, just in terms of the level of coaching required as well. So that's another question that we have from an implementation perspective is we've been doing 8 months of intensive coaching, and what we really want to look at when we reflect on the data is what is that critical moment where you get marginal benefits, right, with more and more activity. Mm-hmm. So that's another point of analysis that we also want to discover through the collaboration and other sites implementing the checklist is what type of support do they provide and what is the outcome that they see, because that would be a really important piece of information for scale up and other places.
Like, for example, the Japago Dakshata model right now is doing an intensive, I think it's like a month or 6 weeks of coaching or their nurse mentoring revision, and then they do 8 visits afterwards. Like, that's their model that they're trying right now, that they're scaling up across India. So it's a great opportunity to look at, like, how are different strategies working or not, and what's actually effective. So it'll be a fun one. Christine?
So you have an approach that seems to be very well developed and so on, and yet there must be huge diversity in the way that it's actually implemented.
Yeah.
Could you speak a little bit about that?
Sure. I think, one of the things that I didn't show in the graph that showed this, dramatic improvement in behavior is the variation across the sites, the pairs that are there. There are some of the intervention sites, 2 out of the 15 in the intervention sites didn't really budge.
Yeah.
Just behavior didn't really change. There are some of the control sites that actually had better behavior than they did at baseline. What's that attributed to? We don't really know. We've got some recording in the data to understand that. The variation on the implementation, what I think is interesting is, as part of the launch event, there's a gap analysis that's conducted by the facility staff along with the coach. They sit down and talk about what are they concerned about, what are the areas of effort that need to be worked on. So that first visit is different based on what that gap analysis showed. So not every facility is working on like pause point 1 at visit 1. It's what was identified by the community, the facility staff, about being problematic, and how can you try and address that early on. So we have information on that, like what was coached on at each visit and how coaches and the team leaders reflected on what the problems are. There are times when they also just decided that a problem was no longer coachable. Like they had been trying to solve the problem, they had been trying to fix it, and just having no success, and they've tried everything they can think of. And at some point it becomes demotivating to keep coming back to that and just hammer on it, right? So dropping that and going back to something that you think you can see the behavior change on. So part of the interesting thing about working across 60 intervention sites and 60 control sites is that you can see like what worked in some facilities didn't work in others. And in India, in UP in particular, I think this is probably true everywhere, the geographical differences, in UP they call it east of Kanpur. So the districts that are east of Kanpur district, which is like smack in the middle of the state, everything that's gone to the east has been notoriously harder to work in, right? So understanding what's working in those facilities and districts that are supposedly more difficult, as opposed to the places that are closer to Delhi, which seem to be quote unquote easier to work in. Yeah.
Good.
Thank you.
We're wrapped. Thank you so much.
Thanks.
And I have to make you promise now again publicly that you'll come back with
Yes,
results.
absolutely. We'd be happy to with whatever. It's funny, we were working on key messages this past couple of weeks, and of the 3 possible outcomes, like no impact, big impact, mixed impact, and how we would think about it to try and get everybody's brains wrapped around the fact that it may not work. I mean, it may not have an impact. We hope it does, but we'll see. That's why we're asking the question.
We did a very big trial with vitamin A in Ghana some while ago.
Yeah.
We showed no effect on maternal mortality,
Yeah.
stillbirth, and morbidity. Like everything had effect size 1.01.
Yeah.
So nothing. And there was a very wise person on our advisory committee who'd been sort of like director of health services, and we were saying negative findings, no effect, and he said, no, you have authoritative evidence that's going to save a lot of money, because
Yep.
we would have done this with no evidence, and he just had this wonderful way of turning it around.
So I told Atul, the past 2 trials I've run that have been very large trials had null effect. So the chlorhexidine trial in Zambia, and definitive evidence of no impact in Zambia, and as well as one of the breastfeeding studies in HIV. So I told him that this is my legacy. So warning now. yeah, 3rd time lucky maybe. But anyway, but thank you. I'm happy to stay and answer questions if you want me to answer anything individually. But I appreciate the time. Thank you.
Thank you.
And also to say that